Hello, welcome to this workshop on strain echocardiography in 2020. My name is Victoria Delgado from the Leiden University Medical Center, and it's my pleasure to work with you on how do we use strain imaging, strain echocardiography in 2020. With echocardiography, we have two main techniques to assess myocardial deformation or strain. We use mainly either tissue Doppler imaging or two-dimensional strain echocardiography, which can be later on used as a vector velocity imaging or speckle tracking echocardiography. With tissue Doppler, we measure the velocities between 2 points, the velocity gradient, over a segment with a fixed distance. And therefore, we assess the deformation of that segment along the ultrasound beam, which means that if we are assessing the four-chamber view, the apical four-chamber view, we only can assess longitudinal strain, the shortening along the ultrasound beam. But if we use the short axis view, we can assess the thickening in the anteroseptal and anterior segments and in the posterior and inferior segments of the myocardium. Therefore, tissue Doppler imaging and strain derived from tissue Doppler imaging is angle dependent. In contrast, two-dimensional strain measures the relative displacement of two kernels, 2 points of the myocardium along that distance, and tracks those fingerprint or those two kernels along the direction of the wall, and therefore is completely angle independent. And the disadvantage that has in comparison to tissue Doppler is that it's frame rate dependent. So when we have very high heart rates, we are going to see the 2 points moving along the direction of the myocardial wall at two different times, and we may lose part of the peak of strain. These are the two technical points that you have to keep in mind. From tissue Doppler, we depart from velocity, and then we do a spatial derivation for which we have a strain rate. And if we do the temporal integration, we will have strain. But this is only along the ultrasound beam. If we go to the apical segments, we may have a zero deformation because it's completely perpendicular to the ultrasound beam. The movement of the myocardium is perpendicular to the ultrasound beam. And therefore, we need to be very careful how we acquire the images in order to make sure that we have a good alignment with the ultrasound beam. This doesn't happen with two-dimensional echocardiography with two-dimensional strain. When we use two-dimensional strain imaging, so speckle tracking mainly, we take into consideration the myocardial fiber disposition. And we know that the myocardium has a subendocardial and subepicardial helix. And what we have is the subendocardial right-handed helix and the subepicardial left-handed helix. And by deforming these two different layers along the cardiac cycle, what we have is a shortening of the longitudinal direction, shortening along the circumferential direction, and through those two shortenings we have a radial thickening. And here is what we have on the images moving: the circumferential strain, the shortening along the curvature of the myocardium, longitudinal strain along the longitudinal direction, and from both shortenings we have the radial thickening. How do we measure global longitudinal strain, which is the modality that is being most frequently used in clinical practice? So basically, we take the 3 apical views, the 4-chamber, 2-chamber, and 3-chamber apical views, and we trace the endocardial border, and the software derives the deformation of the myocardium along the entire myocardial wall. And therefore, we have the shortening of the myocardium in all the segments, and we can get a bullseye plot, as you can see here, that tell us the longitudinal strain of each segment. The average of those values leads to the global longitudinal strain. And based on the value of global longitudinal strain, we can indicate whether that function of the myocardium is normal or not. Here, for example, you can see the different patterns of global longitudinal strain. In a healthy individual, the values go between -18 to 22. In a patient that has a myocardial infarction, for example, like this patient in the middle with an anterior myocardial infarction, you can see that the areas that are affected by the infarction, they have a much lower magnitude of the deformation, and the values can range between 10 and 15%. And when we have a heart failure patient, you can see that there is no much deformation in all the segments of the myocardium, of the left ventricle, and that leads to very poor values of longitudinal strain. So, which are the clinical implications of measuring global longitudinal strain, for example? And I'm going to put you one of the examples that is more frequently used and the specialty that probably has embraced much earlier the use of global longitudinal strain than any other subspecialty in cardiology, and that is cardio-oncology. In this study from the St. Jude Lifetime Cohort Study, including 1,800 patients, the authors compared the 3D left ventricular ejection fraction with global longitudinal strain and also with circumferential strain. And what they showed is that there were many more patients with already some myocardial dysfunction when we use global longitudinal strain or when we use circumferential strain. While when we use 3D left ventricular ejection fraction, the majority of the patients appear to have a normal function. And these values have implications in terms of how they correlate with the clinical status of the patient. Actually, many of these patients, they could have reduced functional capacity even if they had a normal three-dimensional ejection fraction. So in summary from this study, only 6% of the population had an ejection fraction based on 3D echo less than 50%, but systolic dysfunction detected by global longitudinal strain and circumferential strain reached almost 32%. So these have important implications. It has been said also that there are different vendors and that maybe the different vendors do not have the same values. That has been solved. There is a task force that tries to homogenize the values of global longitudinal strain across the different vendors, and even with platforms that are vendor independent and that can measure global longitudinal strain or circumferential strain from 2D data. And as you can see, the inter-observer reproducibility across all these vendors and the vendor independent platforms for assessment of global longitudinal strain, they have a much better reproducibility than ejection fraction. So this is also another reason in order to be more familiar with the use of global longitudinal strain and assess left ventricular systolic function with strain imaging and not so much on ejection fraction. Therefore, I would like to conclude that myocardial strain has become regular in clinical practice, particularly in cardio-oncology, but many other subspecialties of cardiology are increasing the use of global longitudinal strain. It's more sensitive to changes in left ventricular systolic function than ejection fraction. It can be automated, the measurement of global longitudinal strain, and therefore introduces a very little opinion of the observer and increases the reproducibility between observers and within the same observer. I hope that you like the workshop, and I hope that you start using much more frequently global longitudinal strain in clinical practice. Thank you very much for your attention.